Please welcome Shannon Brownlee from US Lown Institute.
Thank you so much. I'm really pleased to be here. You live in an incredibly beautiful place, but we have met a few of your colleagues and found really warm and very generous people, and also people who are very committed to taking care of patients. As a writer, I want to tell a story, and I need a little clicker to do it. Here we go, thanks. Thank you. I want to tell you a story about this man. When he was about 50, he began having terrible headaches. And as you can see, he's a sculptor. He's about 80 years old in this picture. But when he was 50, he began having terrible headaches. And he put up with them for a long time, and finally he fainted from the pain. And his wife took him to the emergency room, and they had a new device, a CT scanner, and they found that there looked like there was a tumor in his brain. And they rushed him to the nearest big city, and he had surgery. And he ended up having 3 different surgeries, brain surgeries, and it saved his life. Now, this was a benign tumor, a meningioma, but it was growing in a part of his brain that was going to eventually harm him. So brain surgery was this amazing, life-saving thing. It took him several months to be able to speak again, to be able to work again, but he did relearn. And then about 10 years ago, there's another story to tell. He was a scholar of Chinese art, but he was unlucky enough to be a scholar at a time when he could not go to mainland China. But then mainland China opened up, and there was an exhibit near his home in Seattle, Washington, of the bronze bells of the Shu dynasty. And his son offered to take him to this exhibit, and he was very excited to go to the exhibit. And his son took him there, but the man couldn't really walk very well, and he was finding himself feeling more and more exhausted, and finally he sat down in the middle of this exhibit that he had waited his whole life to see. And he said, "Take me home." And what was happening was he was suffering a side effect from taking a statin, and he was taking a statin for one risk factor, which was ever so slightly elevated cholesterol. And his muscles began to break down, and he was hospitalized, and he nearly lost his kidneys. This man is my father, and he died last November, and I can tell you that we're incredibly grateful as a family for the extraordinary power of medicine to heal. He also exemplifies the power of medicine to sometimes harm, especially when it's given when it's not needed. And this statin that he was on was for a tiny elevation in cholesterol. In fact, his cholesterol didn't change. What changed was the guideline for whether or not he was supposed to take it. So I tell you this story to tell you that I have enormous respect and gratitude for the great things that medicine can do, but I also know that it can do better. So I want to talk about overuse today. Overuse is a sort of umbrella term for a number of things. Overdiagnosis, which is something that happens a great deal these days because we screen for diseases. It's when a patient is diagnosed with a condition that either would not have bothered them over their lifetime. Prostate cancer is the poster child for this problem, or could have been caught later and treated successfully later. Overtreatment is a test, a procedure, a hospitalization that is not going to benefit the patient. Now let me say what is not overtreatment. It is not overtreatment when you give a patient whom you suspect strongly has an intracranial hemorrhage. You give the patient a CT and you do the CT and they do not have a hemorrhage. That is not overtreatment. It is overtreatment when the patient has absolutely no signs of any neurological problem, and they get a CT scan because either the patient demanded it or because the physician was worried about being sued in the United States or out of an overabundance of caution. So there are some definitions for what overtreatment is. But I want to ask a question of this audience. How many of you take care of patients? How many of you put your hands on patients? Nurses, physicians. So many of you. How many of you have seen a patient receive care they did not need and should not have had? Many. How many have seen a patient be harmed by it? So there is growing awareness of this problem, but it's a little bit like Darwinian evolution 100 years ago. It's very hard to accept. And it's hard for patients to accept because they don't want to think that there is any such thing as too much care. We have persuaded our populations that more is always better when it comes to healthcare and when it comes to medicine. But I think it's also really hard for you, the good people who care for patients, to accept as well. Very hard to accept. And I understand that, but I hope that by the end of this talk, I will have persuaded you that overuse is a significant problem in the United States and is probably a significant problem in Norway. I hope to persuade you that it has multiple causes, but chief among those causes is the industrialization of healthcare, especially in the United States, but in all of the developed world, and it turns out in middle-income countries as well. Every country we've looked at, every country where we have colleagues, there is evidence of overuse, including places like China and India that are still grappling with infectious disease. And finally, addressing the problem of overuse will require more than just technical fixes like clinical guidelines, because it is deeply embedded in the culture of medicine, and it is also deeply embedded in patient expectations. And so if we want to change this, it's going to take more than changing the way we pay. In the United States, we do need to do that. It's going to take more than guidelines. It's going to take a shift in the way we train young clinicians, doctors and nurses, and a shift in the whole way we think about the purpose and the goals of medicine and the relationship to patients. So with that, I'd like to go on. These are some categories of overuse, and I can talk a little bit about them. But they're really sort of broad categories. So effective treatment that is used on an inappropriate patient, there are many examples. The most famous, of course, is probably antibiotics for an upper respiratory viral infection. CT scan is routinely overused on the wrong patient. It's this incredible technology. In the United States, about 30% of CT scans are unnecessary, and they are causing cancer. There's an estimated 6,000 deaths per year, excess cancer deaths per year, because of the overuse of CT scans. Carotid endarterectomy was widely used on the wrong patients, patients who were asymptomatic. Implantable cardiac defibrillators are given to patients who don't really understand what they're for and are unlikely to benefit. So then there are things that are now being called low-value treatments or ineffective treatments, or treatments that have very little possibility of benefiting patients. The PSA test is one of those, the prostate-specific antigen test for prostate cancer. CA-125 test is for ovarian cancer. Inferior vena cava filter to prevent pulmonary embolism. Vertebroplasty for spinal arthritis. Steroids for spinal injury, spinal fusion for many indications of back pain, head imaging for syncope. And then there are unproven treatments, treatments that are used, especially in the US, but I think often in Europe as well, that are used before there's evidence that they're effective. So the one that is most recent, of course, is renal denervation for hypertension. A randomized controlled trial recently showed that it was no better than sham surgery. Orthognathic surgery. We do a lot of hospitalization that's unnecessary in the United States. And there are many drivers of this, why patients end up getting hospitalized and put in the intensive care unit unnecessarily. And then there is a very different category, and this is one that I think is very important and not very well understood, which is that there are many things that are elective, certainly surgery, for example, for if a woman has breast cancer, she has a choice. Breast cancer, she can have a mastectomy or lumpectomy. That's kind of the classic example of an elective procedure, bypass surgery, prostatectomy for early prostate cancer, and end-of-life care. And patients, it turns out, when they really understand what the pros and cons are, what the potential benefits are, what the potential harms are, they tend to be more conservative, and they tend often to choose differently than if they're not really well informed. And there are pretty good estimates for how much surgery and how much end-of-life care patients undergo that they would not have wanted if they had been better informed. So this is a matter of ethics. It's an important situation. So how much unnecessary care is there in the United States? Anybody want to bet 5%? Anybody want to bet 10%? Between 10 and 30% of what we spend is on unnecessary care. This is a phenomenal amount of unnecessary services. It's a phenomenal amount of money. We're talking $800 billion a year. 10 to 30% of hospital admissions for chronic conditions, heart failure, diabetes, end-of-life care, are unnecessary. Not only do we spend a lot of money, we expose patients to the risks of medical error and the risks of infection when they are hospitalized unnecessarily. 30% of imaging tests are inappropriate, MRIs and CT. 12 to 15% of PCI, percutaneous coronary interventions, stents, catheterizations, are on inappropriate patients. And this is by some pretty conservative estimates. Others would estimate that it's a lot higher. So these are just a few of the examples of care that is delivered in the United States. And so we'll talk a little bit about what percentage might be possible here in Norway, what percentage of the care that you deliver might be unnecessary. But it's clearly an issue in the United States. Oh, and hip and knee replacements. Now, how do we know? Well, there's growing evidence, and it's coming from a lot of different kinds of sources. So we know about overdiagnosis because of some randomized controlled trials, recent randomized controlled trials of prostate-specific antigen testing for prostate cancer, mammography for breast cancer screening. A trial just came out in Canada. So that's one kind of overdiagnosis that can happen. When you give a patient with uncomplicated back pain an MRI, you increase the chances that that patient is going to be diagnosed with some kind of condition, maybe a ruptured disc, maybe some other kind of deformity, and that often leads to overtreatment. In the United States, spinal fusion is one of the fastest growing surgeries among patients over 65 years. So we also know back pain, obviously, is being overtreated in the United States. Stenting and angioplasty. And then this paper recently came out, a colleague of ours, Adam Elshag, in Australia, and his colleagues looked and found 150 low-value medical services that were being delivered in Australia. They're also being delivered pretty regularly in the US, and I suspect they're being delivered in Norway as well. And I'll give you a few examples, and then this is the most recent one. This is a randomized controlled trial, finally showing that renal denervation for hypertension was not effective, and it's widely used in the United States. So this is a more recent paper that talks about how often does this happen, and it happens a lot. It happens a lot. They looked at only 26 low-value procedures and tests, and they found that 42% of Medicare beneficiaries received at least one of those. And Medicare, by the way, is our one area of our healthcare that's actually single payer, that's provided by the government, and it's only provided to patients over 65. The majority of Americans get private, or actually about 50% of the care is covered by private insurance, which is mostly comes through their employer. We have a crazy system, in case you didn't know. So, of those 26 different low-value services, 2.7% of Medicare spending, and this was 2009 numbers, $8.4 billion. Today, it's about $16 billion of the money that we spend on Medicare goes towards just these 26 low-value services. And there are many, 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 many other low-value services that are being paid for and that patients are receiving. So that's one kind of evidence. This is another kind of evidence, sort of looking at the frequency for specific conditions. This is a different kind of evidence. This is looking at geographic variation. And I show the picture, this is California, a map of California and 30 different hospital referral regions in California. And I show the map of Norway because California and Norway are roughly the same size. This is not to scale, obviously. Norway's a lot longer. There are also a lot more people in California. So what this is looking at is rates of stenting and angioplasty and catheterization in these different regions. And there is a 10-fold difference between the lowest and the highest. A 10-fold difference in rates of these cardiac procedures. Now, there are a number of ways to interpret this kind of data. But one thing we know is that this is not being driven by how sick patients are, by the rates of heart disease. These data have been adjusted for age, sex, race, and for rates of heart attack in the different regions, which is a pretty good measure for rates of heart disease in these different regions. So there's this 10-fold difference. So what's going on? One possibility, and it's the reddest regions are the highest regions and the yellow regions are the lowest regions. And so one possibility is that in those yellow regions, people are not getting enough stenting and angioplasty. Now, what's interesting is the yellow regions are right next to red regions, and so it's not as if they have to drive very far to be able to get. And most of these, by the way, are elective. We do about 750,000 procedures a year, stents and angioplasties a year, and probably half of those are elective, maybe more. So it's not as if they don't have access to a catheterization lab. So another possibility is that in those very red regions, dark red regions, people are getting more procedures than they need. And there's pretty good evidence for that. So there have been 2 studies over the last 10 years that looked at actual cases, more than 1 million cases, and analyzed those cases on whether or not they were appropriate according to the American College of Cardiology guidelines. And in the first study, 15% were inappropriate, and in the second study, 12% were inappropriate. And at some hospitals in the United States, 50%. No, excuse me, I'm sorry, I'm misstating. 20% were inappropriate, clearly inappropriate. That is a lot of stents and angioplasties. And in this population, in this study was looking at stents and angioplasties, they found that the rate of unnecessary procedures was 8 per 1,000 beneficiaries, about 392,000 low-value stents in 2009. That is a huge number of people exposed to a procedure that, while low risk, is not zero risk. So you might conclude that American doctors sometimes think this way. For those who you can see it right there. But, you know, it's funny, but it's not. And here's why it's not. Let me tell you a story about a patient that I know. A woman named Marilda. I'll call her Marilda. She's a Brazilian immigrant. She lives in upstate New York. And she began feeling very anxious. Her son was going away to college, and she was studying to become a nurse's assistant. And she found herself with her heart rate up, breathing hard, and feeling very, very anxious, and beginning to feel like she was having chest pains. And she went to the emergency room. And in the emergency room, they checked her out for the possibility of heart attack, of course, and absolutely clean as a whistle. No evidence of anything going on. So they said, you need to go to your primary care doctor. She went to the primary care doctor, who instantly sent her to a cardiologist, who checked her out and said, absolutely nothing going on. And she said, I think I'm having panic attacks. And she may have been. Her husband was beating her. In addition to worrying about her son, in addition to trying to study to get this new job, she had an abusive husband. And so he checked her out and said, you're fine. So she went to the emergency room again, and she went back to the cardiologist, and he said, okay, let's do a catheterization just to be sure. So she went in that morning, and she actually remembers seeing on the screen, at the moment the doctor said, your heart is absolutely perfect, and she remembers looking and seeing the picture on the screen, and then everything went black, because he perforated her, and she went into cardiac arrest. She had to be resuscitated 9 times. And now she really does have heart disease. She's on 9 different drugs, and she can't work. She can't walk her dog. She can't walk upstairs without breathing hard. Now she really does have a problem. So it is a low-risk procedure, but this was a woman who really needed someone to talk to her about her family situation. What she really needed was to find ways to be able to deal with her anxiety. And instead she was harmed by a fairly low-risk procedure, but not zero risk. So the sheer number of discrete procedures and tests that are ineffective or potentially harmful, or that are used inappropriately in all specialties at all stages of patients' lives, from birth until death, should be a signal to us to how easy it is to give patients care that they don't need. And the question, I think, for you is, how big a problem is this in Norway? So if we look just at stenting, there's the United States, the 2 countries that are above the United States, Germany and Belgium. I don't know what they're doing, but that's an awful lot of cardiac procedures. But look who's next, Norway. It's a lot of cardiac procedures. Now this is, I think these data are from 2009, and these may have changed. Our rate has gone down slightly, not very much, but slightly. So there's a hint that there may be a problem here too. There are other kinds of evidence, and you'll hear a little bit more about this kind of evidence, variation work. But this is a little bit like the map of California that I showed you. This was looking at variation in the delivery of radiological services, MRIs, CT, X-ray, across the country in Norway, and there was significant variation. There was overall, the rate per 1,000 varied by a factor of 2.5. MRI varied from 170 per 1,000 to 2 per 1,000 in different parts of the country. CT from 216 to 56 per 1,000. And the problem of overuse has clear implications for the United States, but I think it has implications for you as well, for all health systems, in fact. One of those implications, obviously, is budgetary. So this is a graph looking at health spending per capita compared with GDP, and here's Norway. You spend a lot on health care, but you also make a lot. Your GDP is very high. This is our crazy number up here. But the real issue is how fast healthcare spending is rising. And in most of the developed world, most of the OECD countries, health care expenditures are going up faster than GDP. And that is a real problem for the United States. It is a crisis problem for the United States. It means in the United States that we are not spending money on other things that people need, like schools and roads. We know of communities in our country where the town managers are having to make decisions about what they can spend money on. Can they cover all of their employees? Can they give them health insurance? Or can they get a new teacher for the school? Employers, part of our unemployment problem, about 2 out of the 8% of unemployment in the United States is due to rising health insurance costs. We are suffering real consequences now of our out-of-control healthcare spending. And Norway is this green one of these green ones. Your spending is going up faster than GDP as well. So we're just going to go broke faster than anybody else. But we're all going in the same direction. So it's an issue. But the really much more important reason to be concerned about overuse, to me, is the potential for harm to patients. So there is real harm happening. 3 to 10 million unnecessary hospitalizations, that leads to 44,000 to 132,000 unnecessary infections in the United States. Unnecessary deaths from medical error, 21 to 63,000. This is a lot of harm. And it is not intended harm, it is just one of the consequences of putting people in the hospital when they don't need to be there. 80,000 unwanted elective stents and angioplasty. The way we get these numbers is that if you look at patients who get fully informed about what the potential costs, potential harms, and potential benefits are of stenting, they're about 20% less likely to choose getting a stent, an elective stent. They are 20% less likely. And since we do so many stents, that amounts to 80,000 stents and angioplasties a year that the patient would not have wanted had they understood what the consequences might be. And that is at 1% risk of a serious adverse event. That's a fair number of people who are harmed. 250,000 unwanted joint replacements, 90,000 unwanted prostatectomies or radiation for early prostate cancer. They have real consequences. 800 people in the US are harmed from an unwanted stent. An estimated 17,000 harmed from an unwanted arthroplasty. 45,000 men are impotent or incontinent or both from a surgery that they might not have chosen if they had been well informed. And so, but the most important area in the United States where we have to start grappling with unwanted care is at the end of life. So I want to tell you a story about a woman. I'm going to call her Glenda. That's not her real name. She had advanced dementia. She was about 78 years old. She was living in an assisted living facility. She could not dress herself. She could not feed herself, could not bathe herself, and did not recognize her 2 daughters. She fell and broke her hip, and she was rushed to the emergency room at a very prestigious Boston hospital. And in the emergency room, her 2 daughters arrived at the emergency room, and they informed the doctors that she had signed something called an advance directive. I don't know if you have the same term here in Norway, but 10 years earlier, knowing that she was headed for advanced dementia, she signed documents that said, in the event when she was too demented to make decisions for herself, in the event that her heart stopped, she stopped breathing, she did not want cardiopulmonary resuscitation. She did not want to be put on a ventilator for any reason. She did not want a feeding tube inserted. So she's at the emergency room, and the physicians say to her daughters, we need to do surgical repair of her hip. And her daughters said, but she signed a directive, don't you have to put her on a ventilator to do that surgery? And the doctor said, oh yeah, we temporarily waive that all the time. Then another physician said, we think she's had a little heart attack, we need to give her a catheterization. So they took her to the cath lab, put a stent in, she had to be resuscitated, they couldn't wean her from the vent. And so she ended up on a ventilator. She was on the ventilator for a week, she got an infection, the infection was cleared up with antibiotics, and then she was cleared for hip surgery. She went in for hip surgery on the vent, they couldn't get her off the vent. After 2 weeks, they asked for permission of the daughters to put in a tracheostomy and a feeding tube. And the daughters grappled with this because they knew that this was exactly what their mother didn't want. And they finally said, we've gone this far, we need to give her every chance. So they did the tracheostomy, they put in the feeding tube. She went back to the assisted living facility, but in a much more intensive care part of the facility. She went back to the hospital 3 times, twice for an infection, once because she yanked out her tubes. She was put in wrist restraints. And it was at this point, when she was hospitalized yet again, that someone from the palliative care team was called in. And they looked over her records, her voluminous records at this point, and they looked over her records, and they called the daughters in 2 days later, and they said, do you think this is what your mother wanted? And they said, no, we're absolutely certain this is not what our mother would have wanted. And so together with the palliative care team, they were able to make the decision. They took her off the ventilator. She died surrounded by her family. This was not an unusual case. Has anyone here seen a case even remotely like this? This is what most of us don't want. And yet it happens all the time in the United States, and I suspect it happens here as well. So this is what we call futile end-of-life care. This is care that prolongs dying, increases suffering, or violates the patient's stated preferences. CPR, ventilation, total parental nutrition, feeding tube for an elderly patient who is suffering from multiple organ failure, advanced dementia, and inoperable terminal condition. And I have to tell you, as the child of a patient who knows a lot about this, I couldn't prevent this in my own father who died last November. It was difficult to slow this process down long enough for my family to be able to talk to palliative care. And my father was hospitalized for 10 days, which is exactly what he didn't want. We finally were able to take him home to hospice, and he died 10 days later with his family. So these cases are a tragedy, I think. I think they cost an enormous amount of money in the United States. The average of $350,000 of health care over their lifetime. It's closer to $500,000 if you include nursing home care. $50,000 of that is in the last year of life. So we are spending a lot of money, but in fact that is, again, not the main reason to be concerned. This is a paper that was published in Health Affairs about Norway, about a number of European countries, and it looks at what kind of systems you have in place, symptom recognition to diagnosis for patients with dementia. Diagnosis linked to community service, home to hospital and back, home to residential care, home or residential care to palliative care at the end of life, and here's Norway. And I'm amazed that we actually have one more than Norway does, because we have pretty terrible care for the end of life. But this makes you suspect that these kinds of gaps in the services that allow people to have the care that they want, to be cared for at home, to be cared for where they want to be cared for, at the hospital if that's what they want, it makes you wonder if you're really, if you may have this same problem as well. So I think what this does is it brings up the ethical and public health dimensions of overuse, which are the crucial dimensions of this. First of all, patients suffer. They suffer harm when they receive procedures they don't need, when they receive hospitalization they don't need, when they receive tests they don't need. Because even if the benefit is zero, the risk of harm is always there. Overdiagnosis and overtreatment of the well leads to undertreatment of the needy, and this is a crucially important point. In the United States, it's very, very clear that we are making trade-offs between public health and social services and the enormous amount of health care that we deliver that patients wouldn't have wanted and didn't need. We are making very direct trade-offs. And so we have undertreatment at the same time that we have overtreatment. We are wasting a huge amount of money, but we're also wasting people. We're wasting resources that should be used to care for people who really need them. And finally, Iona Heath, writing in the BMJ, said that our devotion to biomedical activity marginalizes and obscures the socioeconomic determinants of health. This is especially true in the United States. Americans think that A, we have the best health care in the world, and B, that health care is the thing that keeps us alive. Well, number one, our life expectancy is really bad compared to every other OECD country. Not every other, but many, most. And number two, we are not realizing the importance of things like education and poverty and clean air and clean water and good food as determinants of health. But I think there is another dimension to this. I think that it is the harm that is done to clinicians. I think this is not recognized well. This system wears you out. In the United States, physicians and nurses are feeling worn out. Many of them, particularly in primary care, feel like gerbils on a gerbil wheel. I don't know if you have children who have little pets that run on a little wheel. But they feel like they are on a treadmill, going as fast as they can to stay in the same place. And you are the very people we patients need the most. We need your compassion, we need your skill, we need your sense of duty and social mission. And if we waste your time doing things that we don't need, we don't have your time, we don't have your labor, we don't have your sense of compassion and goodness when we really do need you. Overuse is an assault on the clinician's sense of integrity, on the clinician's sense of self, and it damages our collective belief in the goodness of medicine. Now, what's causing it? Just a few things. In the United States, these are some of the causes of overuse. I don't want you to read them all, it's too many and it's too complicated. But it's what we call in Boston a wicked problem. It's complex, it's pervasive, and until very recently, it's been very, very difficult for people in the United States to even recognize that it was going on. And what this says is there's no silver bullet here. The silver bullet is, I don't know, is there a term for silver bullet in Norwegian? It's the thing that you kill werewolves with, or vampires with. There's no single wonderful solution to this problem. It is very complex. It is in our DNA, or as ethicist Howard Brody said at a meeting, it's in the air we breathe. Overuse is part of culture of medicine, it's part of patient expectations. And patients actually have no idea how often they are given a treatment that won't help them and that might even harm them. And they have very magical beliefs about what medicine can do. So 27 patients with incurable terminal illness believe they can be cured. 54% of patients with inoperable small cell lung cancer think they can be cured. 32% of patients with terminal AIDS, 22% with chronic heart failure, 12% with chronic obstructive pulmonary disease believe they will be cured. So there's a lot of magical thinking out there. And you, luckily, do not have the problem of a gigantic profit-driven healthcare system. So this is a wicked problem. What are the steps that are needed? In the United States, we really have to reform our system from top to bottom. We need to change the way we pay. Right now, most of healthcare is paid for with fee-for-service, so there's an automatic incentive to do more volume. Higher volume brings in higher profits. We don't have a very good primary care system. We only have 35% of our physicians are primary care physicians. We need to make primary care community-based, especially for the frail elderly. I think we both need to do that. We both need to increase awareness of overuse. We need to transform medical education so that students understand it. We need to change behavior, and we need to change patient expectation. And I acknowledge that what I am proposing here is not trivial. It's huge. It is an enormous issue to grapple with. But the first step, I think, is being aware of it and acknowledging it. And if you think that radical change is not necessary, I think you have not yet perceived the profundity of the problem. And if you believe you don't have anything to offer this, I think you have not paid attention to the history of change. My country has gone through enormous cultural change. If you think just back 50 years ago, civil rights in my country for African Americans. This was an enormous cultural shift that happened. It is possible to do. And we can have an impact on the people around us, but we have to have courage. We have to be able to speak up. We have to be able to acknowledge what's going on. So I want to tell you a little bit about the work that we're doing at the Lown Institute. We think that change only happens if we go through these steps, that there is broadening understanding, awareness first, understanding, buy-in that a problem is ours to fix, and commitment to doing so. But I think there's another piece of this, which is you need to find fellows. You need to find people who have who are worried about the same thing and want to work together, because it's hard work and you do need colleagues. So our strategy is to build a network of clinicians in the United States and internationally. Clinicians who are concerned about overuse. To find ways to take action to draw attention to the problem, to increase awareness. We want to use conferences and meetings to build solidarity among people who are worried about this issue and want to do something, and to plan future work together. And one of the first things that we did was we founded, with several people, we founded an organization that is called the Right Care Alliance. This is a national organization starting. It's a network of clinicians, nurses and doctors, but also community leaders. We are holding conferences as part of this process of building this network. We are having regional meetings around the United States and possibly in Europe. We have a declaration of principles, which I encourage you to take a look at. I hope that you will consider signing it. We're trying to recruit new members to the Right Care Alliance, and we are trying to devise actions to prevent overuse. So we are building this network through these various groups. We are convening a number of organizations. We're doing convenings. We have a meeting coming up in March in San Diego. If it's kind of cold in Tromsø, I hope someone will come. We also have some specific activities, something called Do No Harm Project, which was created by 2 young physicians at the University of Colorado, and it's a very, very simple project. Very simple project, easy to implement. They basically gave residents who were in training a day off to write up a case of overuse that they see, and the best of these cases are being published in the Journal of the American Medical Society, the Internal Medicine, Journal of Internal Medicine. Right Care Rounds is another project that's being developed, which is a way of using the grand rounds to really focus on cases of overuse and really analyze what's going on. We are publishing papers in journals. Our various people around the US and around the world are starting to write about overuse, and we're looking forward to working with them. We're promoting shared decision making. How many people know about shared decision making? This is great. Fantastic. So shared decision making is a crucially important part of reducing unwanted care. And we are also considering doing something that we're calling Right Care Action Day, which would be across the United States and possibly in other countries, where people all take some small action at the same time to look at overuse, to demonstrate overuse, to do something about it, something specific. And this is just the, you can get more information about the Do No Harm Project, which is based in the University of Colorado. And so I'd like to leave you with a couple of quotes. I don't have them by heart, so I'm going to find them. So this was written by, it was written in the New York Times just recently. David Bornstein, who is an expert in social change. And he said, medicine is facing a crisis, but it's not just about money. It's also about meaning. We often think of medicine as a science, and many doctors think of themselves as technicians. But healing involves far more than knowledge and skill. The process by which a doctor helps a patient accept, recover from, adapt to, or endure a serious illness is full of nuance and mystery. Great doctors don't just diagnose diseases, prescribe medications, and treat patients. They bring the full spectrum of their human capabilities to the compassionate care of others. That is why doctors, upon entering the medical profession, speak noble words, like the Declaration of Geneva. I solemnly pledge to consecrate my life to the service of humanity, or the oath of Maimonides. May I see in all who suffer only the fellow human being. Medicine offers you a front row seat on life, meaning is all around you. When you can see it, it gives you a sense of gratitude for the opportunity to do this work. And that meaning is so deeply important to your patients. I know that the tremendous technology of medicine has great power to heal, but really you, all of you, are the true healers. And so I leave you finally with this quote from Dr. Bernard Lown, the founder of our organization, who said, "We must strive to do as much for the patient and as little as possible to the patient." Thank you very much, and I welcome any questions, comments, protests, anything. Thank you.
Thank you very much, Shannon.
My pleasure.
It was a brilliant talk.
Thank you.
So the quote, "less is more," is valid in some cases.
Yes.
And
Sometimes more is more.
sometimes more is more, but
less
in
is
some
more.
cases less is more.
Yes.
And it's all about changing our mindset in a way.
Yes.
So it's a difficult task, but I think you all got some ideas from these talks. So, does anybody have a question for Shannon?
Shout. Oh, we have microphones. Good.
Hello. Hey. Hello, my name is Vanille. I'm an intensive care nurse. Thank you for an excellent lecture.
Thank you.
I miss a focus on building skills to communicate. Isn't that a part of how to communicate with the patient so that we give them the information they need to take their own choices? Isn't that a more important part of reducing overuse of treatment?
I think it's a crucially important part. So I want to tell you a little story. I told this story last night. My mother was fainting, and I took her to the cardiologist because her primary care doctor wanted her to go, and I took her to a cardiologist near me in Maryland. And the first thing that happened was the electrophysiologist did a full workup, and then the electrophysiologist came into the room with my mother and me and sat down and talked for about 5 minutes about what she found, and she found nothing, but she talked for about 5 minutes, and the whole time my mother went like this. And I didn't understand a word. Not anything that and I know a fair amount about medicine, not a lot, I'm not a doctor, but I know enough to ask questions. I could not even find a place to ask a question. And when the doctor left the room, and she was an incredibly nice woman, she left the room and I turned to my mother and I said, "Did you understand what she said?" And my mother said, "Not a word." So physicians and nurses, I think, forget what other people don't know. You have been steeped in what you do for so long that it's hard to remember what it was like before you started learning all of this material. So patients often need things explained to them in phenomenally simple terms, and when you ask them, "Did you understand?" they go like this. They may not have. So I think this ability to communicate with patients, and the really important part is the ability to elicit from the patient, to get the patient to talk about what they care about. So for example, for a man who has heart disease, who might get some small benefit from bypass surgery, some mortality benefit from bypass surgery, but really, really does not want to have any of the cognitive effects, if you don't know that about that patient, it's very hard to share the decision. So the crucial piece, I think, here for shared decision making, and for a huge amount of this, is the ability to communicate with patients, and that takes time. And that is the one thing in the United States that nobody has enough of. And it's crazy. So I hope I've answered your question. Thank you.
Any other questions? We have time for a few more.
I know it's hard to ask questions with 499 of your
No,
colleagues.
it's not easy. Yeah.
You're right.
Yeah, there's one over there.
Hello? Okay. My name is Tone Norway. I'm head of the oncology department. And thank you for a nice talk. One thing is your comment about communication, that it takes time. I think if we had spent some more time on communication, we will, patients will would perhaps say no to some treatment, and we would actually save time. So one thing is the communication between patients, their relatives, and doctors, nurses. And I also think we should spend some more time talking doctors and nurses together from different specialties. Like if we have shared decision-making between different specialties, should big surgery be done on this 86-year-old man, which may end on different devices afterwards? I think if we could spend some more time before we could plan things more properly, I think we would save a lot of resources, and we would take much better care of our patients. So I very much agree with the things you said.
Absolutely. Thank you very much for your comment. I think this is quite the case in the United States, and it sounds like it's true here as well, at least at times, where there's so many people taking care of a single patient, a complex chronically ill patient, a seriously ill patient. And when those clinicians aren't talking to each other and really communicating with each other, it's hard to offer the best care. A little story, I shadowed some palliative care physicians at a very big hospital in New York City. And there was a woman who was suffering from, her liver was starting to fail from cirrhosis, she had kidney failure, she had multiple conditions. And the palliative care physician decided to get all of her physicians, and she was in the hospital, decided to get all of her physicians into the same room. And what was fascinating about what happened is the clinicians didn't communicate well with each other. Each specialty was focused on their organ. So the nephrologist was thinking about one organ, the liver specialist another organ, the pulmonologist another organ, the cardiologist, and they used language that was so hyper-technical that other doctors in the room had a little bit of trouble understanding. So this communication piece has to be focused on the patient, so thank you for your comment.
Okay. So thank you very much, Shannon.
Thank you.
And Elizabeth.
Thank you. I didn't know Scandinavians
So, we will remind you of Tromsø and University Hospital.
You're very kind. Thank you so much.
Thank you very much. So, Shannon is the Senior Vice President of the Lown Institute